Thank you, David. Good morning, everyone. I'd like to thank the conference organizers for the opportunity to present our work on behalf of my colleagues, especially Aditya Khanna, who did all the mathematical modeling for this project but was unable to be here to present it today. And I'm very excited that I was able to follow on Dr. Isiru, who has talked a lot about the implementation of option B+ for the prevention of mother-to-child transmission of HIV in Uganda. And we were interested in estimating what the impact of this change in ART initiation criteria would have on the heterosexual transmission of HIV. And we wanted to do this for two reasons. One, we know that ART prevents HIV transmission to sexual partners, but also we know that HIV-infected pregnant women are more infectious, are twice as likely to transmit HIV to their uninfected male partners. So the research question for this mathematical modeling analysis was whether ART interventions for pregnant women can reduce HIV incidence due to heterosexual transmission, and we wanted to come up with a quantitative estimate for the impact on HIV incidence. So just to review, the options for prevention of mother-to-child transmission were option A, which was a short course of zidovudine during pregnancy, option B, which was triple drug therapy during pregnancy and breastfeeding only, and option B+, which is lifelong triple drug therapy for pregnant women regardless of CD4 count. And as we heard in the previous presentation, this is now the strategy in Uganda, and we wanted to estimate what the impact of this strategy is on HIV incidence, specifically from heterosexual transmission of HIV. And I was very excited about the approach that Aditya used to examine this question. He developed a stochastic network model, and it was calibrated to behavioral, biological, demographic, and treatment data for Uganda. And he used this to compare the effect of PMTCT interventions on heterosexual transmission at different coverage levels in Uganda. And this model is exciting because he is able to look at every individual in the population and characterize their HIV status, CD4 count, viral load, HSV2 status, and all the cofactors for HIV transmission, including things like male circumcision. Other work in this area has estimated that option B+ is cost-effective in regards to incidence reduction in children and adults, and these analyses were done in Kenya, Zimbabwe, South Africa, and Vietnam. We were focusing on Uganda, where the fertility rate is high and where we expect the benefits of this to be substantial. So we developed the network model and we calibrated it using data from our studies of home HIV counseling and testing in southwestern Uganda. And we have data over time. We asked individuals about their sexual behavior, about their last 3 partners, and for HIV positive persons had their CD4 count, viral load, and ART initiation and viral load after 12 months on ART. And we simulated these interventions over 10 years and compared horizontal incidence between the different implementation strategies. And we also used other published sources for some of the biological data and the treatment parameters. And this slide just shows that we were able to capture some detailed demographic factors, including mortality and births and age structure. We did not explicitly track vertical transmissions. For the behavior characteristics, we've estimated from our data that the duration of partnership was approximately 11 years, and the momentary distribution of the number of partnerships were for 13% of women, 13% of men, and 2.5% of women reported at least 2 partners. And the frequency of unprotected intercourse was 2.4 sexual acts per week. And we were able to do age mixing by categories defined in 10-yearly increments. HIV transmission in the model was determined by a function that took into account viral load, pregnancy status, circumcision, HSV2 prevalence, and ART status. And we assumed that individuals with a viral load of less than 100 copies did not transmit HIV infection. For treatment, we looked at both prevention of mother-to-child transmission and ART, and we changed those categories for eligibility, coverage, and initiation, and I'll show you the details in the next slide. So we modeled 3 scenarios for PMTCT and ART, and we looked at, for PMTCT, for at the current intervention coverage and adherence, which was 48% coverage and 88% adherence. And for ART, we looked at a low coverage of 49% and 89%, and we compared both those strategies to the best we could do for PMTCT, which was starting PMTCT at 14 weeks, achieving a 90% coverage and 75% adherence. And then we also looked at the best ART. In here we used the CD4 count of 350, but we could have used 500, but with high coverage of 90% and an ART adherence of 88%. So I'm going to show you the results in the next slide. And the first slide just shows you that here the prevalence of HIV, about 10%, as predicted by the model in the black line, compares well with what is observed in the blue dot. And here are the results, looking at the impact on HIV incidence of these various strategies. And I'll just walk you through this busy slide. So here for option A, we see an incidence of about 1%. So this is with low ART coverage and also with low PMTCT coverage. When we increase the coverage of just PMTCT, which is the second column here, we see that for each strategy we see a reduction in HIV incidence, and the reduction is shown here. So under just the best we can do for the prevention of mother-to-child transmission, which, to remind you, is high uptake of PMTCT and high adherence, changing from option A to B would see a 3% decrease in HIV incidence. Changing from option A to option B plus would see about a 26% decrease in HIV incidence. But of course, the most significant impact on HIV incidence is high ART uptake for everyone. So changing the guidelines with high access to ART and high adherence. So here, bringing the incidence down from about 1 to 30%, and in this last square here, looking at the incidence when you have both high access to PMTCT and ART. In the next slide, we just wanted to share also the incidence over time, and you can see here that the program over 10 years has an incremental effect on HIV incidence. So here in the solid line, we looked at the current implementation level for both PMTCT and ART. Then in the dashed line, we looked at the impact of the best PMTCT uptake, and in the dotted line, we looked at the best impact of ART uptake. And you can see here a significant reduction with the best rollout of the intervention as we could expect. And this was for option A, and then here in the blue line what it would look like for option B, and then here in the red lines what it would look like for option B plus. And you can see here very similar trends for option A, B, and B plus. So regardless of which intervention you choose, option B plus has a significant decrease in the number of new cases of HIV due to heterosexual transmission within the population. So we learned from this modeling exercise that investing in PMTCT treatments can significantly reduce heterosexual transmission, especially in high fertility settings such as Uganda. So this is additional support for rolling out option B plus. It does have a substantial impact on HIV incidence due to heterosexual transmission, as we expected relative to options A and options B, but this analysis gives us a quantitative estimate of what that impact would be. And scale up of ART for everyone has the greatest reductions in HIV incidence, but future work should evaluate the costs of this, and very importantly, we need to work on the implementation science questions and the operational questions of rolling out both PMTCT and ART for prevention in Uganda. And I'd like to conclude by thanking our collaborators, and our funders. Thanks very much.